So we're going to talk about TAVR Horizons Partner 2, SurTAVI, and beyond. You know, a lot of this has already been brought to you by Matt. Matt did a great job of summarizing the progression within the SAPIEN family of trials. And I have to say, you know, this is the data generated by the US ID trials is without any question the best data of valvular heart disease that has been generated anywhere on the planet at any time. I have a lot of competing things. You know, as Matt says, he does the balloon expandable talk when he's up there with Marty, and then, no, he does a balloon expandable here, but he does self-expanding with Marty. We kind of all do a variety of these valves. You've seen this, you'll see it a zillion times if you come to these. We all have these slide. You know, if you look at the high risk, survival was equivalent in the Partner A trial in high risk randomized. The core valve, it was superior at 1 year, 2 years, and at 3 years, it lost its superiority for just all-cause mortality. That's only because we're moving to lower numbers. We still have a delta of 6.2. The only way to maintain superiority as you go out is to continue to widen out, which of course in mortality curves is impossible because we all come to a single point at some time. We all die. Now, if you look at the high-risk trial, one of the things I asked when I presented this at 2 years, and we now have it out to 3 years, is how are we going to do in lower risk? It didn't surprise me that TAVR could do well against surgery in high-risk patients. Because as a surgeon, I can do a perfect job replacing your aortic valve, take perfect care of you, and you still die. You're just too sick. You can't get over it and you die. But as we move down the risk scale, it should depend more on how well we take care of your disease and less on the invasiveness of the procedure. And so we took everybody in the high-risk trial that had an STS less than 7, because 7 was the median STS of the first data cut of the TVT commercial registry here in the US, and said, how did they do? And they were superior at 1 year, 2 years, and 3 years. So even as we move down the risk scale in this subgroup analysis, we seem to do fairly well. Now, why is that? Well, that's because if you look at the surgical arm, one thing you see that's repeated in all the trials over and over and over again is you have more life-threatening bleeding, disabling bleeding and transfusions, more acute kidney injury, and more atrial fibrillation. Why is that important? All these have an early effect on your mortality, an early hazard ratio, and an ongoing effect on your mortality. They don't just hurt you when they happen, they hurt you over time. And what happened in the TAVR side? Well, we had more major vascular injuries. But what Matt showed you early on was, as we moved to these smaller devices, the difference in vascular injuries has gone down. And there was more pacemaker implants in the self-expanding valve, but even those have gone down. And so far, pacemaker has not been identified in this trial as a cause of mortality. But now again, we're talking about older patients and not too much time. We also found that at every data point, the forward flow hemodynamics were superior for the TAVR valves in surgery. Again, that's, you know, how much does that matter? Well, all these things, your long-term survival is going to be a compendium of all these things. The other thing we asked ourselves about was, how about structural valve deterioration? If we define that as a greater than 50% increase in the baseline gradient after treatment, how is that? Well, it's very low in both, but higher in surgery than TAVR, which actually should be easier because surgery started higher, so you'd have a bigger increase to reach 50%. This is some data we're going to present in more detail at the American Association of Thoracic Surgery this year. I took the high-risk randomized trial, and I looked at every single death, and I calculated an instantaneous hazard ratio of death. And I looked at a procedural group, 0 to 30 days, a recovery group, 1 to 4 months, and a constant group. In the procedural group, at least in TAVR, the yellow line, almost all the early deaths were these technical disasters, because these were all new sites that didn't know how to do it. We punctured ventricles, we ruptured things, bad stuff that's really largely gone away now. But by 1 month, all of a sudden surgery and TAVR came back together. But then surgery went back up again, and they came back together at 4 months and stayed constant. Why is that? Well, Stanford did a really interesting study where they looked at the timing of death after cardiac surgery in the US, and there were 2 peaks. Anybody want to guess when those peaks are and why? One peak was at 6 days, and one peak was at 40 days. Why is that? Well, at 6 days, these people are just so sick we can't keep them alive. And the definition of surgical mortality is you live 30 days and you get out of the hospital. So you live 30 days and we send you to the LTAC, and then you die. And that's why the second peak was at 40. And this is what you're seeing right here in this surgical line. These are people that went off and just never recovered. Now, by 4 months, you're past that, and you get into the constant hazard where how well we treated your disease should start to matter and your underlying physiology. So what do the randomized trials tell us? Because for TAVR to be competitive with AVR, we really have to show equivalent or better mortality. Well, TAVR wins that. I'll just have to be as good as. Hemodynamics, TAVR wins that. Quality of life, I didn't show you any data on this, but I can, the data is out there. It's equivalent. TAVR gets better faster if you do transfemoral, but by year, both of them have really good quality of life improvements because they both relieve aortic stenosis. Patient acceptance, I didn't show you any data on this because everybody walks in my office wants a TAVR. Sometimes I say, you really came here with coronary disease. You don't need a TAVR. And I read about the TAVRs, doc. That's really good. Morbidity, PVL and pacemakers, still need to work on those, but they're both getting better. And durability, we just don't know. And we're not going to know from these early trials. These people are 83 years old. They're not going to live long enough to tell us. So how about lower risk data? Well, this is what's happened in the TVT registry. In the last cut for the transfemoral, the mean STS was 5, which we would consider by STS intermediate. Partner 2A, Matt showed you this. Again, it's a randomized trial. In intermediate, it was with the second generation XT. The primary endpoint was all-cause mortality or disabling stroke at 2 years. Age is still 81. One thing we saw is less anesthesia time, less procedure time, and the median length of stay in ICU and the hospital is much less for TAVR. We showed you a case yesterday, a live case of a valve-in-valve and a guy that had 2 previous sternotomies for heart surgery. The entire case took 45 minutes. I saw him this morning on rounds. His question to me was, can I go home? His wife's question to me is, can he play golf tomorrow because he's going to want to? I told him, yes, you can go home, but I'd prefer you wait till next weekend to play golf. I can't do that with surgery. If you look at the all-cause mortality of disabling stroke, Matt showed you this. It didn't reach statistical significance, but TAVR was numerically better if you look at the entire group. But if you look at the non-inferiority, with a non-inferiority margin of 1.2, you look at the numbers you get, that gives us a relative risk ratio of 0.92 with an upper one-sided of 1.9. That clearly makes non-inferiority at the 0.001 level. If you look at the primary endpoint of all-cause mortality or disabling stroke in the as treated, again, it's numerically better for TAVR, but it does not reach statistical significance. And again, this was the subgroup analysis in a forest plot. Only 2 groups favored surgery, an EF greater than 55% and a non-femoral access. Non-femoral access, if I put a hole in your chest, you just don't do as well. If you look at transfemoral primary endpoint, in the intent to treat group, 0.05, and the as treated group, 0.04, superior. And 90% of the cases done in this trial were transfemoral, and that's really where we're going. So we're already seeing superior. Again, major vascular complications, more common in TAVR, but look, they're much closer than the trial I showed you before. And what else do we see? More bleeding, more transfusion, more acute kidney injury, and more AFib in the surgical group. A constant theme that goes to every single trial with a hazard function that starts now and goes on into the future. Matt showed you this, better hemodynamics. Matt showed you this, PVL rates of about 8%. Versus almost no PVL in the surgery. Core valve SurTAVI trial, that's an intermediate trial that I'm privileged to run right now. I'm hoping we're going to shut this down soon, and I'm hoping to present the initial data at the ACC 2017. Partner 2A and S3, the S3 was a intermediate risk trial with the most current generation. Matt showed you this. I'm not going to go over it all. The only difference was that it was a non-hierarchical composite of all-cause mortality, all stroke, or greater than moderate aortic regurgitation at 1 year. There's a non-inferiority trial for the primary endpoint. It very easily made non-inferiority. This was then compared against the Partner 2A surgical arm, as Matt showed. It was very easily non-inferior. It was superior when compared against the surgical arm for the primary endpoint. It was superior when compared to the primary endpoint for the components, individually, mortality, stroke, but AR was superior in surgery. Not a surprise. We still do better as surgeons. I'm not going to go over this. Matt showed you this against superiority in this post-hoc, non-contemporaneous trial, but it does show you where we're going. And unadjusted time to event for all-cause mortality, again, numerically better in TAVR. What was really amazing to me about this, and something we found with our use of the S3, is the paravalvular leak rate has gone away to almost nothing. We used to accept some paravalvular leak because it was a less invasive procedure, but now we almost never accept paravalvular leak in the lab. It really surprises us to see paravalvular leak. Notion trial was just a Nordic trial. It was an all-comers trial, very brave trial. Started in 2009 as a superiority trial. Composite endpoint of all-cause death, stroke, myocardial infarction in the as-treated population. Did not reach its endpoint of superiority, not a surprise, but it was numerically less for TAVR. It was numerically less if you looked at the components of death, stroke, or myocardial infarction. All of these, if the trial had been bigger, would have reached statistical significance. but they just didn't have enough people in the trial. There's 2 low-risk trials going on. One is the Medtronic low-risk trial that I have an opportunity to run. It's going to be about 1,200 patients. There's going to be a subgroup of leaflet motion abnormality, 1-to-1 randomization. There's an Edwards Partner 3 trial, same thing. I think, Matt, you're going to do part of this trial where it's going to be a randomization between surgery and TAVR. They're both fairly similar. They're both ongoing. There are some slight differences. Partner is an STS less than 4. For ours, it's STS less than 3. Partner has an age floor of 65. We have no age floor. And pretty much everything else is the same, a little bit different in our endpoints and our timing of endpoints. But I think this is going to be the last great frontier, low risk, randomized. Once we answer this question, then we just move on to bicuspid valves, and there aren't many more questions to answer out there. PVL, these are the valves that we currently use. I haven't put up the Portico. We're going to start using Portico soon. If I did this talk in about 2 more weeks, we'd then put the Portico up there. But what do we know? We know from the in the direct flow medical valve from the discovery trial in Europe, at 1 year there was no moderate or severe paravalvular leak, none. Starting to look a lot more like a surgical valve. We know from the Reprise 2 in Europe at 1 year, no moderate or severe paravalvular leak. Only 11.4% mild. That looks like a surgical valve. We know from the S3, Matt showed you this, but then we're at sub-4s. And the same thing for the Evolute, sub-4s. This is how the trend has gone in 1 month moderate to paravalvular leak, and this is how it's gone at the 1 year rate. You can see we're coming down, and all these are starting to look a lot more like surgical valves. So my predictions for the future is that paravalvular leak will be largely solved and similar to surgery with engineering design improvements. I have very little doubt in that. This is another reason why I think it's going to move into low risk. This is looking at your stroke volume in the randomized trial between TAVR and surgery. Your stroke volume doesn't drop after TAVR. Your stroke volume drops after surgery. Why does your stroke volume drop after I operate on you? Because I freeze your heart. I put cardioplegia in it and I freeze it. That is not good for your heart. Now it recovers, but it takes about 6 months to recover. What else happens? There's more RV dysfunction in surgery than there is in TAVR. Again, because when I give you cardioplegia and freeze your heart, it is not a good thing for your heart. So my other prediction coming forward is that surgical aortic valve replacement hurts the heart for at least 6 months. This is not going to change as we move into lower risk populations. It'll be better tolerated, but it's still going to occur. The other thing is surgery is a mature technique. It's been around for 60 years. I've been personally doing it myself for 32 years. When we started the trials, I've been doing surgical aortic valves for 32 years, and Dr. Kleiman and I have been doing TAVR for 0 days. And so we were comparing a mature technique against something that was just starting. And so TAVR is young, and it's likely to undergo substantial improvements, and it's already undergone substantial improvements. In fact, in just a little over a decade that it's been here, the growth of this and the improvement is just outstanding. The technical disasters which occur have already been largely displaced by better techniques. The other prediction is that surgery is a technique-driven trial. Technique is something that takes 10,000 hours to become an expert in. You got to do it over and over and over. TAVR is technology-driven. Technology is much easier to learn. And in fact, what this is going to do is it's going to make this available to more people in more areas of the U.S. Just like descending thoracic aortas, it takes a lot of time to learn to do a good surgical descending thoracic aorta. I can take anybody in this room and I can help you do a TAVR in a good descending aorta with a good neck up and down, and you'll do it and you'll learn how to do it in 2 weeks. So it's going to enjoy a wider adoption. We used to ask which cases are bad for surgery, and we do TAVR. I think the paradigm is shifting, and we're now asking which cases are bad for TAVR. Maybe we'll do surgery in those cases. Well, that's another issue. And we also talk about risk. We used to draw these little risk boxes. There aren't boxes for risk. Risk is a continuum. It grades from low risk to extreme risk. And there's really 2 bars, one above which we don't go because you're just too sick, it's futile, and one below which we haven't gone because of the data. But both those bars are moving to the left. And it's really going to depend on durability. And if we show that durability is found, my final prediction is this is what it's going to look like for people that need tissue valves. Thank you very much.